Okay, we're going to look at Chapter 4, Therapeutic Communication. These are the objectives that we'll be covering, the importance of communication, how normal and pathological changes affect it, person-centered communication, and ways to improve. There are a lot of key terms that you'll be reading about in your reading, but again, the importance of understanding the differences of these. Again, 2 pages of them. It's so long. There's just so much about communication, understanding all the problems that can occur and how do we overcome them. So let's take a look at that. Some of the basics is we have to look at how we provide and receive information from others. We have to look at that message that's going on, understanding that it is dynamic, and we are to be looking for feedback from that person. It does rely on all the senses to pick up and receive, and what is really important is to have a conducive environment. You definitely are going to have to go in and turn the TV off. Make sure that you're positioned to that person, that they're not cold or distracted by other noise in the room. We do a lot of verbal, and as you'll see from the videos, the importance of nonverbal and how we can engage that person. It is definitely what we call person-centered. We focus on that patient and how they perceive things in their own experiences. Our goal then, or with our interventions, is to really provide all the information that we can to promote health. And we want it about self-care. That's the whole thing with the older adult, is to keep them as independent as possible. When we have patient-centered communication, it really confirms we believe in that uniqueness of each individual, and we will adapt what we need to so that they can participate in their own care. The obstacles that we see as we go through working with communication is there becomes a lack of opportunity and more social decline. People are retiring, they don't have maybe spouses or as many friends, their children's don't live as close. One of the things that improving communication now is the internet and iPhones, and I don't know what I would have done without an iPhone when my mom was in her last year of her life, living so far away, that I actually went out, bought my dad an iPhone, made sure he learned how to FaceTime so that my mom could see me. And that does, because I didn't want to be away from them. We also have to look at the physical and mental impairments that may interfere with their ability to communicate. So strategies that we need to do when patients have dementia and we're trying to support their person, we want as best we can is to get in that they recognize, that there is recognition, and that can be very difficult. You don't want to be in situations where you have to do a lot of negotiating. You don't want to give a lot of choices. You need to keep it simple. We need to validate the way they are feeling, and we want it to be facilitative and a collaborative approach. There is a term called elder speak, and we really need to keep it simple, or the KISS methodology. It is all about respect. We need to simplify or reduce some of the complexities of our grammar and vocabulary. And what do we mean by that? Well, I can remember as a new nurse coming out of school, and we were taught we were supposed to use the appropriate medical terms. And I had a gentleman that had dementia, certainly wasn't very well, what I would call educated from a school point of view, and I was, do you have to void, do you have to go to the bathroom, and this guy couldn't understand me at all, and I finally said, do you have to pee? And because it was simplified, he knew it, then I could get him to go to the bathroom. So you've got to get down to the level that we're at. But it has to be respectful. Okay, it has to be very respectful. You have to watch your pitch. It may have to soften up, but you don't want it totally like baby talk. Don't be saying honey and sweetie. That's just not appropriate. I do have a lot of good information on you out there for you about health literacy. It is very important in nursing nowadays that we understand the definition of health literacy and to be culturally competent. How do we work with individuals of different cultures that, as we're trying to teach them to take over their care, we have to evaluate what they understand. One of the best things to do is the teach back method by having someone tell me the information I want them to do is the best way they can demonstrate it. Communication in the end of life care, this is really complicated because everyone is in such a emotional state they may not be hearing all the message. So you really have to be clear, simple in your message, straightforward, and a lot of times you have to make sure that they have truly heard your message, because when people are in emotional states, we don't always think the clearest. The changes that we see, the visual changes, it takes longer to adjust from light to dark. Their lens of the eye may appear yellow. Glossy magazines, glare is a real big issue with the aging eye. Hearing changes, we lose that ability, the conductive loss. Sensory loss is the most common. Other vision changes, to go back to that, you have to think of dry eye, glaucoma, cataracts, macular degeneration. So there's a lot of things that we see with that aging person. And about 21% of people over age 70 have both hearing and vision loss. Cognition changes, short-term memory loss, long-term memory loss. Short-term is the first to go, so it's great to be able to do life review and have them reflect back. One of the things I love is if I'm in a nursing home or in someone's room, I look at the pictures on the wall. Tell me a story. Tell me where this happened. And you just watch this person just go back in time. It's wonderful. That declarative memory is your factual loss. So that fact isn't just quite there, and the story may be just a little embellished. The pathological changes with cognition, awareness, speech and language dementia is one of our biggest. It is memory loss accompanied by speech and language impairment, and Alzheimer's being the most common form. But we see that decline, and not only do we have cognition decline, but they lose that ability to form sentences, to get the words out. The speech slows. You also have to do oral, make sure that their teeth are fitting or not fitting. Do they have a dry mouth? And that comprehension will also decline with hearing, vision, and sensory, all the way to aphasia. There are compensatory strategies people will use. They do a lot of head nodding, and so you really have to be aware of what are they getting across. So we will want to have them repeat back what is happening. That rehab strategy or restorative strategies are skills that we want to help them build, and it may just be as simple as picture recognition. Point to an apple, point to a pen, point to a bowl to see what it is they're understanding. With your communication strategies, page 114 and 115 of your book does a fantastic job with this. But again, with their vision, include the patient, provide large print, non-glossy, make sure that their glasses are on. Please make sure they're clean. It's sometimes as simple as just cleaning their glasses. Again, when they're hearing, you want to speak slowly. I'm a very fast talker. and I have to really just slow my cadence down. You may have to know what ear is, or both ears if they have hearing deficits. Speak into the ear. This is not good if you have a group going on. Have one person speak at a time or they just can't hear that message. With their cognition, slow it down. Like I said, use the words that they will understand. When they do have speech and language problems, again, put yourself with them, say their name, try to include them. Excuse me. Many good strategies that you can do, and the book has a beautiful job on that. We also remember that when it's communication, we have families, and as our aging population is in their 90s, we're teaching children that are in their 70s. So you almost have to look for some of the same problems with the family member as you do with the patient you're trying to take care of. Always include that older person as much as possible. Remember, we do have HIPAA laws. You need permission to communicate to family members. That can be very difficult. We also have to teach family, especially with a person with dementia, what is normal changing. This is very frustrating. I told you this 17 times and they're not remembering. They have no ability to remember. So to work with that family through their frustrations. The other thing is we cannot take care of the aging person alone. This is very multidisciplinary. We have to model to our other paraprofessionals around us. We have to be models for the CNAs. We have to be models for people that are helping out feeding or cleaning and bathing, and we just have so much that we can role model with. And show that family member, hey, watch this intervention I'm going to do with your mom. Let me see you try it, and try to include them in and let them practice with you in the room. So again, as you read and look at the activities in this chapter, you really need to be aware of the different impairments that we'll be facing. Realize appropriate techniques will help. And really, as you leave this chapter, understand the importance of evaluating your client's health literacy.